Good evening, everyone. Welcome to the online lecture series. All right, we are going to have our first session of the online lecture series for the preparation of NEET in 2025. All right. So this is going to be a special session for the critical care paper. And point of care ultrasound is a very important topic for critical care physicians and for your NEET examination. I'm Dr. Midhun Mohan, faculty in emergency medicine and critical care from Doc Tutorials. So let's begin. It's going to be a long session because the indications as well as the uses of point of care ultrasonography is so vast. So we are going to split the sessions into two parts. So I'll be covering mainly lung ultrasonography as well as cardiac sonography and DVT evaluation in this session, and the remaining things like approach to abdominal pain, trauma, ocular ultrasonography, all will be dealt with in the next session. Okay, let's begin. Now, point of care ultrasound is a goal-directed bedside ultrasound examination. What you're doing this or trying to find out is to answer a specific diagnostic question or to guide the performance or an invasive procedure. Okay, so it's very much a focus thing. All right. We are not performing a complete evaluation like a radiologist. We are trying to find out whether our suspicion of a condition is correct or not using point of care ultrasound. Okay, and it can help with a lot of procedures as well. Now, why POCUS is very important and very helpful, and it is becoming a valuable or invaluable tool for us for any emergency physician or any ICU doctor, is because it can be done at the bedside itself. We know most of the ICU patients can be unstable, and it is not safe to shift these patients for CT scanning or even ultrasound examination by a radiologist. So most of the ICUs will be having an ultrasound machine, and you are capable, and the intensivists as well as the ICU doctors there with minimal training, proper training, I would say, they can perform bedside ultrasonography just as good as a radiologist for diagnostic purposes as well as for procedures. Okay. Now, of course, we know it is non-invasive. That's why we prefer it. Moreover, CT scanning as the initial screening tool in many of the conditions. Okay. And because it's non-invasive as well as the radiation risk is very minimal, we can use it in multiple times. So it's repeatable. Now, it has more sensitivity and more specificity compared to chest X-rays. So many of the respiratory conditions, you can rely more on ultrasound than the X-rays. Now, it can assist in procedures, as already mentioned. Then basic ultrasonography can be easily learned with good training as well as practice. Okay. Now, the basic principle, let's see, the questions for your NEET examination can come in different ways. First of all, they can ask some factual questions related to ultrasound findings. Okay, for example, what are the ultrasound findings in pneumothorax? In which of these conditions lung sliding will be present? Those kind of things can be asked. Then most probably, most of the clinical scenarios, they will be having some kind of clues from the ultrasound examination, from the POCUS examination. For example, a patient coming with breathlessness, point of care ultrasound examination is showing bilateral B lines or absent lung sliding. Then what is the diagnosis or what is the next line of management? Okay, so those kind of questions are much more likely. All right. And finally, if it is also possible that they could ask image-based questions, okay, either as part of a clinical scenario or just by showing an image, they could ask what is the finding, what is the next line of management, those kind of things. Okay. Now, so it's very important that you know a little bit about the basics of ultrasonography. Okay, some direct questions can be asked from this part as well. All right. But in today's lecture as well as in the next part, what we are not going to cover is how to perform an ultrasonography. Okay, we are not going to teach how to get a particular image, what sort of images you should get, and how to read those images. In depth, we are not going to cover it. But some basic things you should be able to know so that you can remember. See, if you are a first timer, not used to doing bedside ultrasonography, you need to know a little bit of basics to understand what we are going to talk about. Okay, so those things we are going to cover now. All right. So we know that the principle of ultrasonography is actually echo. All right. Echo is when sound waves are reflected back. We know that in animal kingdom, many animals like bats use echo. Now, when they use echo, they identify the distance of an object by determining how long the sound takes to come back to them. Okay, so they make a sound and they wait till they hear it back. And by determining how long it has taken, they can understand how far an object is. All right. Now, by how much sound waves which is coming back, they can also understand the quality of the substance or the object in front of them. The same principle is being used in ultrasonography as well, right? Now, the only difference is that many of the animals can use infrasound as well as ultrasounds, but only humans can hear between a range of 20 hertz to 20,000 hertz or 20 kilohertz. Okay, that's our hearing range. So we cannot hear ultrasounds which are beyond 20,000 hertz. Okay, now why we are using ultrasound in this machine is that, see, these are high frequency sound waves. All right, these high frequency sound waves have smaller wavelengths, so they can penetrate into these tissues much more easier. Now, we are using these kind of echoes for other things like sonar and all in ships and all. Okay. Now, this is what I was talking about. See, these waves, these sound waves have a wavelength and a frequency. Now, this is important because as the frequency increases, the resolution of the image is much more increased. That means we get more clear images. But as the wavelength increases, we are able to penetrate more. That means more deeper tissues can be seen only if the wavelength is more. Now, frequency is the inversely related to wavelength. All right. So there is a compromise here. Now, if you want to see deeper structures, you need to use lower frequency probe with higher wavelength. Okay, so you can see deeper structures, but with less resolution. So they won't be that clear as compared to superficial structures, which can be seen using a higher frequency probe. So higher frequency probe, we can use only to see the superficial structures like skin, soft tissue, muscles, nerves, blood vessels, and all. But if you want to see the structures inside the abdomen and all, you need to use lower frequency probes, which have longer wavelengths. All right, I hope that's clear. Now, how these ultrasound probes produce these sound waves, ultrasound waves, is by the effect of piezoelectric effect. Okay, piezoelectric effect actually produces sound waves by converting electrical energy. So it converts electrical energy into sound waves, okay, which is actually a form of mechanical energy. Now, this is actually something called as a reverse piezoelectric effect, because the actual or direct piezoelectric effect means that when a pressure is applied, it can become or a mechanical energy is given, it can be converted into electrical energy. So both these things are actually happening in the ultrasound probe. Okay. By piezoelectric effect, there are crystals there in these probes, ultrasound probes. It can convert electrical energy into mechanical energy, which is sound waves. It goes and hits a structure there or any object there in the body, gets reflected back, and these sound waves are then again converted into electrical signals inside the transducer itself and is produced as an image on the ultrasound screen. Okay, very simple. All right. Now, these are the usually three probes that we use, usual three probes that we are using in the ultrasound machine, mainly for the point of care ultrasonography. These include the linear probe, which is also called as the vascular probe, because it can be used for seeing the superficial structures. Okay, it has got higher frequency. Now you have the curvilinear probe, which is mainly used for seeing the abdominal structures or the deeper structures. It is of a lower frequency. Okay, these are a large convex or curvilinear probe of lower frequency, which is around 3 to 5 megahertz. Then finally, you have the cardiac or the echo probe, which is also called as a phased array probe. This one here, the third one there. Okay. Now, it has also got a higher frequency of 7 to 12 megahertz. Okay. Somewhere in between the curvilinear probe as well as the linear probe. Okay. Now, based on, see what you are seeing here at the probe's tip here, that is called as a footprint. Okay, you can see the linear probe has a flat footprint, curvilinear, just like the name, has a curved footprint. Okay, phased array probe is also a microconvex probe. Okay, it has a small curved footprint. And right, so when you are seeing these ultrasound images, you can make out what kind of probe you are using based on the footprint here. See the curve here, large curve here. So this is a curvilinear probe. See the small curve here or the microconvex here, convexity here. So it's a phased array probe. And this one is straight here. The footprint here is straight. So that's from a linear probe. Now, we always look at the probe orientation. That is very important. And that is made out by looking at something called as a probe marker on this transducer. You can see there is a pointer here that is called as a probe marker. This helps us to identify the structures in the ultrasound image where we are keeping the probe, and it will help us to get a good orientation where the image is, or where the image as well as the structures. Okay. So you can see in the image, the marker is over here. Okay. Usually by convention, we keep the probe marker facing the patient's head or caudally, or placing towards the patient's right side. That's by convention. Okay. For us to identify and learn these structures much more easily. Now, there are different modes which can be produced by these transducers. One is called the A mode, which is not commonly used. It's called the amplitude mode as well. Now, most commonly used or the 2D mode, which we are seeing, it's also called as a brightness mode. Okay, this is the image where we get everything in a gray scale. All right, something in between white and black. Everything appears like that. And that's the most commonly used mode, which is called as the B mode or the brightness mode. Then you have something called as the M mode. This is also very commonly used. And it is also called as the motion mode. And finally, we have Doppler modes. Okay, there are different Doppler modes, spectral modes, those kind of things are also there. Okay. Now, this is an A mode. Now, this is called as a B mode, okay, or the brightness mode, where you can see all these structures. Okay. Now, M mode is a special kind of mode where in the B mode itself, you are putting a line here, okay, a marker line here, okay, and you are taking only the tissues. You want to see only the tissues, what's happening to the tissues along this line over a period of time. That is called as motion mode or M mode, because it is seeing things over a period of time. Okay, so these things keep on moving like this. These lines will keep on moving. That is called as the M mode. Now, this is the Doppler mode, where you can see the vascular structures really well, mainly used for assessing the vascularity. And we have different views. Most commonly, three views are being used, which is the transverse view, longitudinal view, as well as the coronal view. Okay, this is the longitudinal view, and this is the transverse view. All right. Now, in the longitudinal view, you can see the structures in this order. See, we are keeping the probe here with the probe marker oriented towards the patient's head. Okay, so this is the superior structures which are seen on the image. The inferior structures will be seen on this part. This is the anterior part. So near the probe, what you are seeing on the screen, on top of the screen, will be the skin, the subcutaneous tissue, then peritoneum, those kind of things, if you are looking at the abdomen. Okay, and deeper structures or the posterior structures will be seen lower down in the screen. Now, in the coronal plane, you are placing the probe here in this orientation with the probe marker, again facing towards the patient's head. Again, superior and inferior structures will be seen in this line here. Then here, close to the probe or the top of the screen will be the lateral surface, lateral part of the patient. Lateral structures will be there. So the skin will be there, subcutaneous tissue will be there. And deeper intra-abdominal structures or the medial structures will be appearing towards the bottom of the screen there. Now, this is in the coronal plane. This is similar to that of the CT. You are keeping the probe marker oriented towards the left side. That is by convention. Okay. So this is the anterior structures will be seen in the top part of the screen. The posterior structures will be seen at the bottom part of the screen, and left lateral structures over to this side, right lateral structures over to this side. Okay. Now, in ultrasound imaging, everything is described in terms of echoes. Okay, we know in CT we are saying in terms of density, and in MRI we are saying in terms of intensity. Like just like that, in ultrasound we are saying things in or explaining things, the findings in terms of echoes. Okay, echoes in relation to the surrounding structures. Now, if the object of interest is more wide than the surrounding structures, we call that object hyperechoic. So there is an hyperechoic object seen here. Okay. Now, if it is darker than the surrounding structures, we call it hypoechoic. Now, if it is, suppose there is an object here and it is of the same gray scale as that of the surrounding structures, it is isoechoic. And finally, if it is completely dark, pitch black, that means it is anechoic. Okay, it is absorbing all the echoes and passing the sound waves through it completely. Okay. So this is just an example. So this is isoechoic, where the entire liver is appearing in the same grayscale. Okay. Now you can see the blood vessels here. Okay. Fluid containing structures will appear as anechoic. Okay. Now the kidney, the renal cortex here, you can see it is slightly darker than the liver compared to the liver. So it is hypoechoic. Now, this is the diaphragm here. Okay, this is the right upper quadrant view of the abdomen, and you can see the diaphragm here. It is hyperechoic, more wide uh, compared to the liver there. Okay, so that's how you describe the structures in the ultrasound. Now, finally, the reporting of the ultrasound. Okay, now you can give purely technical report just like lung sliding is present, but that doesn't mean anything unless you compare it or bring it up along with the clinical context. Okay, so this is just an adjunct to your clinical examination, and it is not something to replace your clinical examination. That is very important to understand. Okay. Now, so that was the basics regarding the ultrasound physics or the nomology, which we call it. Now let's move on to the clinical application. So let's start with the case scenario. Okay. So it's an 83-year-old male with past history of diabetes, hypertension, CAD, moderate LV dysfunction, COPD. So you got all the comorbidities there, which we get typically in most of our patients. And this is a patient who has undergone hemiarthroplasty 3 days back. Okay, for a hip fracture which was sustained 2 weeks back. The patient didn't get any treatment at that time, and only 3 days back he underwent the surgery. And now the patient is having multiple episodes of loose stools since last 2 days and sudden onset of breathlessness since last 3 hours from the ward. And because of this, the patient was shifted to the ICU because of the breathlessness. Now, in the ICU, the patient is found to be drowsy with a respiratory rate of 34 per minute, saturation of 88%, with a heart rate of 78 per minute, blood pressure of 80/50. So you can see that the patient is in hypoxemic respiratory failure as well as the patient is in shock because of the hypertension there. Now, on examination, JVP is found to be elevated, mild bilateral pedal edema is there, more swelling on the right lower limb present. It has been there since the fracture itself, as per the bystander's report. Then just you can get bilaterally decreased breath sounds. Basal Krebs are present bilaterally. S1, S2 is normal. Okay. So what are the possibilities for this patient? This patient can have a lot of conditions, okay, which we need to identify or rule out. Okay, so let's see what are them. Now, since the patient is already a COPD patient, it could be a COPD acute exacerbation. Okay, maybe because of an underlying infection, or maybe because of dehydration from the diarrhea, or maybe because of exertion, or maybe because of pain. There could be acute exacerbation of COPD. All right. Now, it's a COPD patient. There is risk of pneumothorax. So, is there a pneumothorax happening right now? Because the breathlessness is acute in onset. Now, is this patient having a pneumonia? The patient is drowsy. The patient could have aspirated and have developed maybe aspiration pneumonia. The patient has been bedridden for last 2 weeks and had undergone a major surgery now. So it could be a pneumonia because of collapse there. It could be a hospital-acquired pneumonia. 3 days of hospitalization is already there. Now, it could be an infection somewhere else, like a UTI or even pneumonia, and now worsening because now the patient is in hypoxemic respiratory failure. So it could be an ARDS as well, or a non-cardiogenic pulmonary edema condition. Now, it could also be acute pulmonary edema. Patient is already having moderate LV dysfunction. Okay, patient might have had another myocardial infarction, or maybe because of the pain, or maybe because of infection in the body. It could have worsened the LV function, resulting in acute pulmonary edema. Maybe there could be fluid overload during the surgery. Okay, but right now the patient is having diarrhea as well, so fluid overload is less likely. But again, cardiac failure is a possibility. Now, pulmonary embolism, the chance is really high here because the patient has been bedridden for last 2 weeks because of the fracture and undergone a major surgery 3 days back. Okay, so pulmonary embolism, even though anticoagulation might have been provided, is still on the table. Okay, now those are the things which we need to consider when we are thinking about acute respiratory failure. Now, what about the shock? What is the reason for the hypotension here? Okay, now it could be a septic shock from any infection like pneumonia or UTI or a surgical site infection or even a cellulitis. All these are possible. Then it could be hypovolemic shock from the diarrhea, or it could be obstructive shock. Okay, the patient could have a pneumothorax which could have developed into a tension pneumothorax. Patient could have cardiac tamponade. Then patient could have an aortic dissection. All these are possible. So it could be an obstructive shock as well. Now, it could be a cardiogenic shock. The patient could have another MI, or maybe a stress cardiomyopathy, Takotsubo cardiomyopathy, which can also result in a cardiogenic shock. Okay, so all these possibilities are there. Now, how are we going to proceed with this kind of patient who is unstable? Okay, you don't want to shift the patient. You can get your blood investigations, you can do a detailed physical examination, get detailed history. Then you need imaging. Okay, but imaging X-rays, especially chest X-rays in a patient who is unstable, you have to get it in the supine. AP X-rays it's not very accurate. Okay, its sensitivity as well as specificity is much, much less. Okay, most of the time we'll be guessing by seeing something on the chest X-ray without any conclusive evidences. Okay, now to get a ultrasound from the radiologist, okay, the CT scan done, patient is unstable, it's not wise to shift these patients. So the best bet for you here at this point is point of care ultrasonography. Okay, so let's first see what are the things which we can identify or rule out using point of care ultrasonography. Let's look at the respiratory problems here first. Okay, so let's move on to something called as the blue protocol. How can you evaluate for a patient in the ICU who is having an acute respiratory problem or respiratory failure using point of care ultrasonography? One of the most famous protocol is called as the blue protocol, which is bedside lung ultrasound in emergency. Okay, now if you look at this protocol, there are a lot of things which you need to understand as well as you should be knowing. First of all, the protocol starts with lung sliding. So what is lung sliding? Now, is lung sliding present or abolished? Okay, or lung sliding could be present or not present. What is a B profile? What is A profile? What is C profile? What is B prime of profile? A prime profile? Then what is lung point here? Okay, that is the another turning point there. Then you need to know how to examine for thrombosed veins. Okay, then what is this flaps here? So you need to understand all these things before making making any sort of meaning or utilizing the blue protocol. Okay, so let's find out or learn about each of these things here. First of all, lung ultrasound is a very useful investigation tool to identify respiratory pathologies like main stem intubation, pneumothorax, atelectasis, pneumonia, aspiration, COPD exacerbation, cardiogenic pulmonary edema, ARDS, as well as pleural effusion. So most of the lung conditions you can identify using lung ultrasonography. Now, it can help us to guide as well as assess the response to your therapeutic interventions, okay, which can affect the pulmonary system. Like example, giving fluids, okay. We want to find out whether it can worsen the heart failure, whether there is chance of fluid overload, which can result in pulmonary edema, okay. Then whether we need to give diuretics, if the patient is having underlying pulmonary edema or already fluid overload state, we need to actually give more diuretics to the patient, okay. Then endotracheal intubation, then ventilator management, chest tube placement, all these can be guided as well as we can assess the response. Okay. For example, if we increasing the PEEP and you are seeing whether more lungs have been recruited, all right, whether the atelectasis have been overcome, it's now reduced. Okay. Those kind of things we can use the lung ultrasound examination. Now, a little bit of physics about lung ultrasonography is also important. Okay, we are mainly, because normal lung you cannot see through the ultrasound, using ultrasound. Okay, so initially, even if you look at the Harrison's textbook in 2015 edition, they are saying that ultrasonography is useless for imaging lungs. All right, but right now they have changed. In the latest edition of Harrison, they have included the Bluetooth protocol, and lung ultrasound is a very useful tool. Okay, so it's mainly dependent on not on seeing the lung structure aspects, but what we are mainly looking at is called as lung artifacts. Okay, because air is the enemy of ultrasound waves. It doesn't allow ultrasound waves to conduct through it. It reflects most of the ultrasounds back. Okay. Now, majority is reflected due to something called as the acoustic impedance match. That is very important. Okay, that's why air is the enemy of ultrasound. It has high acoustic impedance mismatch, which causes the reflection of these ultrasound waves. Okay, so the lung parenchyma is not usually visualized. And in addition to that, to view the lungs, okay, to see even the lung artifacts, you need to overcome the ribs also. Okay, so through the intercostal space only you can see the lung structures there. Okay, the lung artifacts there. All right, because the bone also is a very powerful reflector of ultrasounds. So there is always this post-acoustic shadowing. Okay, those areas covered by the ribs will appear black in color. All right, those are called as dropout artifacts. Now there are different artifacts which I mentioned, which are unique in many of these pathological conditions. So we are actually using these artifacts. Okay. Now, the man or the person behind this idea of using artifacts as well as ultrasonography is a very good tool to identify lung pathologies is Professor Daniel Lichtenstein from France. He's the man behind the Blue Protocol. Okay, now let's learn about the artifacts in lung ultrasonography. First of all, the pleural line, that itself is an artifact. Okay, you cannot see the pleura, but because of the movement of the visceral pleura over the parietal pleura, you can see, and because that's the point at which air starts. Okay, the interface or the contact with air starts here. This line will appear very much hyperechoic. Okay, so this hyperechoic line here, that is the pleural line. Okay, now bat sign is also described by Daniel Lichtenstein. So he imagined that because the ribs are here, there is shadowing here. Okay, so these ribs here are like the wings of the bat. Okay, and the body here, which shows the soft tissues as well as the pleural line here, that is forming the body of the bat. So this is how it should look like on a normal ultrasound, okay, of the lung. So you should try to get this kind of image, optimal image on the screen. Okay. Now, lung sliding, I already mentioned, it's because of the movement of the visceral pleura over the parietal pleura because of the pleural fluid in between. Okay. Now, lung pulse is again the movement of the visceral pleura against the parietal pleura. But the difference is that lung sliding happens because of the respiration, inspiration and expiration, the movement is there. Lung pulse is happening because of the cardiac oscillations which happens during each pulse. Okay. Now, both can rule out pneumothorax. If lung sliding is present, it rules out pneumothorax. If lung pulse is there, it rules out pneumothorax. Now, what are the other artifacts? A lines. This is something very important. Okay, these are horizontal hyperechoic lines because of something called as the reverberation artifacts. I will explain what that is. Then you can get these sort of short vertical artifacts, vertical lines, which are called as Z lines, R lines, I lines. These are all normal. You don't need to memorize any of them. Okay, but the most important vertical line that you need to be knowing is the B line. It's pathological. Okay, so vertical hyperechoic lines extending all the way down to the bottom of the screen from the top of the screen on your ultrasound machine. Okay, these are also sometimes called as comet tail artifacts or even lung rockets. Okay, these are also reverberation artifacts. So how it's produced is because of ultrasound waves gets trapped between two closely spaced reflectors such as fibrous tissue, pus, water, blood, or even inflammation, which is being surrounded by gas and gets reflected back to the transducer. In simple terms, whenever there is an area of increased density inside the lung, which is surrounded by normal air, you get B lines. Okay, these are reverberation artifacts as well. All right. So let's see a video of normal lung ultrasound findings. First of all, lung sliding and lung pulse. Okay. Now, what you are seeing here is movement of the vessel pleura or parietal pleura during cardiac oscillation. Now, this is during respiration. This is a lung sliding. Okay. Again, this is lung pulse, which is during cardiac oscillations you are seeing. And you can see this sort of marching of ants sort of pattern. Now, that is lung sliding. Okay. Now, what is A lines? A lines are reverberation artifacts. These sort of horizontal lines here. Okay, these horizontal lines. All right. Now, actually, these reverberation artifacts are reverberation of the pleural line here. Okay, so these A lines are actually pleural lines producing more and more artifacts. So what happens is that when you keep the transducer here, first of all, there is a reflection from the pleural line here. Now this is getting reflected back onto the transducer and it bounces back from the transducer, goes back again onto the pleura, reflects back again. This happens like this for many times. Okay. Now, like I said about animals, see, the more time it takes to come back, all right, the first one bounces back easily. Now, the second one comes back, it's going to take double the time as that of the first one. Now, the machine cannot differentiate that. So it feels that, or it mistakenly identifies that line to be farther away from the pleural line. That's why this is seen at equidistance. All the A lines are seen at equidistance. Okay, these are horizontal lines. These are present in normal lungs. Okay, this is a normal lung finding. All right. So these are the A lines. Again, you can see A lines here, equidistant from the probe to the pleural line. Okay. Now, A lines, you can see only if the probe is oriented perpendicularly to the lung. All right. Now, if you are orienting the probe slightly angulated, which is not perpendicular, you cannot see the A lines. So it's very important to have the probe oriented rightly. Okay, you can see the lung sliding also here. Okay. Now, if it is slightly angulated, you can see that the lung sliding is not properly seen and you can mistake it for some other conditions. Now, short vertical artifacts like comet tail artifacts, R lines, I lines, and all, these are also normally seen. Now, M mode, okay. In the M mode, what you can see is something called as the seesaw sign. Okay. Now, it's the same as a lung sliding, but in M mode. Now, in the M mode, what you're seeing is that, see, this is the soft tissue part. Till here is the soft tissue part. And here, the hyperechoic line is the pleural line. Okay. And because of that movement there, beyond that, there is this kind of grainy appearance there because of the movement of the pleura. Okay, because of lung sliding, there is this grainy appearance there. It's called the seashore sign because this part looks like the sky. This part looks like the sea, and this part looks like the beach there. Okay. Now, this is again a seashore sign. Again, seashore sign because of a lung pulse. Okay, lung pulse is producing this kind of seizure sign. And you can see this kind of wavy appearance because of cardiac oscillations. You get lung pulse like this. Okay, now something called as curtain sign and negative spine sign. Okay, now if you look at the right upper quadrant or the left upper quadrant, all right, the lung during inspiration comes and covers the liver on the right side as well as the spleen on the left side. Okay, but because we cannot see the lung, normal lung is not seen, only we can see the artifacts. It appears like a curtain falling over these structures. You can see here. Okay, see how that is covering the liver? Okay, so this is called as the curtain sign. Now, what do you mean by spine sign? Normally, you cannot see the vertebral bodies beyond the diaphragm there because the lung is there and it's preventing visualization of the vertebral body. It ends, you can see the vertebral body in the abdomen, but visualization of that ends at the level of the diaphragm. The thoracic vertebral bodies you are not able to see. That is called as the negative spine sign. Okay, that's also normal. Okay, now in Bullous disease also, you can see sometimes there is reduced lung sliding and pulse. Lung pulse is also reduced. That's a problem. Okay, in Bullous lung diseases. So that is kind of a normal in those kind of patients, Bullous lung disease. Okay. Now let's move on. Now these are called as B lines. The B lines are vertical artifacts, reverberation artifacts, extending from the top of the pleural line, all the way to the bottom of the screen. Okay, so you have to adjust the settings so that you will see at least about 7 to 10 centimeter to the bottom of the screen. Now, if you reduce the depth and make it around 3 to 4 centimeter, you will mistake some of the normal vertical artifacts like Z lines or R lines as B lines. All right. Now, B lines are mainly pathological. Okay. Now, B lines can also be present normally in some areas of the lungs, like the base of the lungs. All right. But if you are seeing in one intercostal region, okay, so in one view itself, if you can see more than or equal to 3 B lines, then that is pathological. Okay. Up to less than 3 lines in one area is normal. Okay, now for lung ultrasonography, we can use all the 3 probes. Okay, but mainly we are using the phased array probe as well as the linear probe. All right, now the position of the patient should be in supine or lateral decupitous position. Both these positions are required. Supine position to see the anterior structures, lateral decupitous position to see the posterior zones of the lung. Now, dorsal segment, the only area of the lung which we cannot scan, this is very important. This could come as a question, is the dorsal segment of upper lobe. This is not seen because it is hidden behind the scapula. Now, to identify pleural effusion, it's better to keep the patient either in seated or semi-seated position. Now, the areas, which all areas should be scanned? Okay. Now, the original blue protocol, they have mentioned actually 3 zones with upper and lower halves. So each side or each lung, you need to look at 6 points on each side. Okay. Now, in the modified blue protocol, they are mentioning only 3 points on each side. Now, in the latest 2012 consensus conference, they said that at least 4 lung areas on each side should be examined. Now, let's look at the modified blue protocol, which are the areas. Okay, to identify these areas, what you have to do is, below the clavicle, you need to keep both hands. You have 2 hands together. Okay, excluding the thumb, like this. Okay, and right at the middle of your first hand, that is the first blue point. All right. Right in the middle of your second palm is the second blue point or the lower blue point. All right. Now the third blue point. Okay. So the first one is in the mid-clavicular line. The second blue point or the lower blue point is in the anterior axillary line. Okay. Now the third blue point on the same side will be actually on the posterior axillary line. All right. So imagine the posterior axillary line here. Okay, keep the prop there. And it should be horizontal to the lower blue point here. All right. So at the same level, go posteriorly at the posterior axillary line. That is the posterior blue point, or this is something also called as the PLAPS point. Okay. This is posterior posterolateral alveolar and pleural syndrome point. That is the PLAPS point. Okay, because you are looking at pathologies like pleural pathology, like pleural effusion, then lung pathologies like atelectasis, consolidation in this area. It's also called as PLAPS. Okay, that point is called as PLAPS point, posterolateral alveolar and or pleural syndrome point. Okay. Now, the normal examination findings include normal lung sliding. In the M mode, the lung sliding will be seen as the seashore sign. Okay. Now, A lines will be seen normally. Isolated B lines is also normal. Z lines may be there. Curtain sign is not there. Absent spine sign. Okay. Or it's sometimes called as absent V sign. That is absent vertebral sign. Okay. All these are normal. Now, what are the findings in pneumothorax? All right. Now, it has lung ultrasonography as higher sensitivity as well as specificity compared to chest X-rays. Now, the position for identifying is supine position in the second to fourth intercostal space in the midclavicular line. What are the findings you are looking for is absent lung sliding, absent lung pulse, absent B lines as well as Z lines, absent seashore sign. Okay, all these are suggestive of a pneumothorax. Now, A lines will be normally present. Okay, so even normal lungs as well as in pneumothorax, A lines will be present. Okay, because again, air is being reflected from the pleural cavity. There is air in pneumothorax that will reflect the ultrasound waves. So it will appear as A lines. All right. Now, barcode sign or stratosphere sign is seen in pneumothorax in the M mode. I will discuss that. Then partial pneumothorax, you can get something called as a lung point, which is very specific for pneumothorax. So this is called as the barcode sign. Okay, there is no lung sliding happening here. And when you put the M mode here, you can see something like a barcode here. Okay, instead of the seashore sign, the grainy area is not there. The shore area or the beach area is not there. Everything appears like the soft tissue itself. So it's looking like a barcode there. This is also sometimes called as the stratosphere sign. Now let's see a video of pneumothorax, the signs of pneumothorax. First of all, you can see that there is no lung sliding happening here. There is no lung pulse also. Okay, now let's compare it to normal. Here you can see the lung sliding there. Now, what do you mean by lung point? All right. Now, this happens in cases of partial pneumothorax. Okay. You see, there is an area of lung sliding here, but there is no lung sliding beyond this point. So this point is called as the lung point. So this is seen in partial pneumothorax. Okay. You can see that lung sliding is present in partially. Okay. So if you are keeping a prop right at the space between the transition from pneumothorax to normal lung, you can get the lung point. All right. Okay, again another video showing the same. Again, this is lung point. You can see here. Okay. You can see the lung pulse is also there in this part, but beyond that, it's not there. Again, a video of lung point. Now, in hydropneumothorax, what you can see is that there is absent lung sliding, plus you can see this anechoic area. This is because of pleural fluid there from the hydrothorax there. Okay, so that is air fluid level. Now, what are the other pathologies with absent lung sliding? This is very important because lung sliding is not specific for pneumothorax. There are other conditions also where lung sliding is absent. But if lung sliding is present, there is no pneumothorax. Okay, but there is always this caveat of having a partial pneumothorax. Then you need to look for the transition zone, which is the lung point. All right. So other pathologies include mainstem intubation. So if you have intubated, the a tube went into the right side, the left side, there will be absent lung sliding. But the good thing is that lung pulse will still be there. So that will help us to differentiate. Okay. Then atelectasis, because of fibrosis there, collapse of the lung there, lung sliding might be absent. Then pulmonary adhesions, as in pneumonia condition, there can be adhesions, then also lung sliding will be absent. Then in apnea, the patient is not breathing, of course, lung sliding will be absent. And finally, in subcutaneous emphysema, the problem is that there is air in the subcutaneous tissue. You cannot even see the pleural line as well as the lung sliding. Okay. Now, other pathologies with a lung point. So, lung point is also not very specific for pneumothorax. It can be seen in other conditions. So, always you need to consider the underlying clinical circumstance also. Okay. Now, it can be seen in bullous disease, like in COPD patients. Then, in lung conditions, also lung point may be there. Then, pleural thickening is there. Then, adhesions. Okay. Some areas will be having lung sliding, some areas because of adhesions, there won't be lung sliding. So it will appear as a lung point. So how can we identify pneumothorax? All right. First of all, look at the pleural line. Identify the pleural line. Is the lung sliding? Yes, means no pneumothorax. Now, if the lung sliding is absent, that doesn't mean there is pneumothorax. You need to look for lung pulse. Okay. If there is lung pulse, again, there is no pneumothorax. But if there is no lung pulse, no lung sliding, look for any other kinds of artifacts, vertebral artifacts like B lines or comet-tail artifacts. If those artifacts are present, then again there is no pneumothorax. But if it is absent, pneumothorax is likely. So absent lung sliding, absent lung pulse, absent other artifacts, vertebral artifacts, pneumothorax is likely. And along with that, if you're identifying a lung point that is suggestive of partial pneumothorax, pneumothorax is highly likely. Okay, so that's how you can identify pneumothorax. Now, what you see in subcutaneous emphysema, that sign is not seen because air is there in the subcutaneous tissue, which doesn't allow you to see any other underlying structures. Now, absent lung sliding, of course, what you can see is sometimes these vertical artifacts, okay, vertical hyperechoic like comet-tail artifacts, but these are not from the pleural line. These are from this subcutaneous air. So these are called as E lines. All right. So ear lines doesn't arise from the pleural line and they do not move synchronously with respiration as in B lines. So that's how you can differentiate between B lines as well as E lines. These ones, they do not move. So these are the B lines, okay, because of subcutaneous air there. Now, what about mainstem intubation? Identification of this condition is more superior with lung ultrasonography rather than with X-ray or even auscultation. Okay, so absent lung sliding on non-ventilated side will be there, but how to differentiate it from pneumothorax? There will be lung pulse present because there is no air in the pleural space. Lung pulse will still be there. Okay. Now, atelectasis, how can you identify it? The main thing here is something called as static air bronchograms. Okay, these are hyperechoic circle-like things in the lung alveoli. Okay, this happens because of trapping of air within the bronchial tree of the lung tissue. All right, which can lead to occlusion of the bronchial tree, which leads to trapping of air inside the bronchial tree. So this air doesn't move with respiration. Okay, it doesn't involve in respiration or ventilation. All right, that is called as static air bronchograms. Now, lung pulse as well as B lines may be present in atelectasis. All right. Now, atelectasis from bronchial obstruction, lung sliding is usually absent. Okay, so lung sliding can be absent in atelectasis. It may be present also. Okay, so it's not very specific. Then compression atelectasis, lung sliding may be present. Okay, so that is the difference. If there is pleural effusion there and it is causing compression of the lung, causing the atelectasis, the lung sliding may still be present. Okay. Now, what about pneumonia? Pneumonia ultrasound is 90% sensitive as well as 98% specific. So it's very good tool compared to chest X-ray. Now, the different findings can be in like lung consolidation itself can be seen. in the form of poorly defined wedge-shaped hypoechoic tissue, which is similar to pulmonary hepatitis tissue. So just like the picture of liver or spleen, just like liver mostly, you can see there is consolidation in the lung, which is same as what we call as lung hepatization as well. You can see just the same picture using the ultrasound as well. Now, there can be unilateral B lines only without any consolidation or hepatization. You can see just B lines in one lung, multiple B lines, pathological B lines can be seen. Okay, so if bilateral B lines are there, you need to suspect pulmonary edema. If unilateral B lines, you need to suspect more of pneumonia. Okay, now there is a caveat that in viral pneumonias, you can have interstitial pneumonia pattern in both involving both the lungs. Okay, so you can get it confused with pulmonary edema. So again, you need to consider the clinical condition of the patient. Okay. Now, thickening and irregularities of the pleural line can be seen sometimes and cannot visualize if it doesn't reach the pleura. That is very important. Okay. Any lung pathology, we are mainly looking at the pleural artifacts. All right. For that, the pathology has to reach the surface, the pleural surface. Now, if there is a malignancy deep within the lung tissue, doesn't reach the pleural surface, you cannot identify it. If there is consolidation deep inside the lung parenchyma, not reaching the pleural surface, you cannot identify it. Okay, but mostly infections, pneumonia, and other lung pathologies, they will involve the pleural surface as well. Okay. So it can have false negatives for pneumonia. Then other signs of pneumonia include shred sign, pleural effusion, and dynamic air bronchogram. Remember, atelectasis is more prone to have static air bronchogram because the bronchi is cut off. Okay. But in pneumonia, the bronchi is usually patent and it can actually cause the movement of this trapped air inside the bronchi. That is called as a dynamic air bronchogram. I will show you some pictures. Okay, so this is something called as the shred line or the shred sign. Okay, so what happens is that there is an area of consolidation here, and the transitions on between the consolidated part of the lung as well as the normal lung will appear irregular like this. All right, there is irregular hyperechoic areas here. Okay, this is called as the shred sign. The pleura is sort of shredded there. Now, air bronchograms, this is important. It can be static or dynamic. All right. Dynamic means it moves with respiration. Static air bronchogram plus absent pulmonary blood flow. Okay. That is seen in atelectasis. All right. Now, this is very important. Okay. In atelectasis, whenever there is collapse of the alveoli there, because of pulmonary vasoconstriction, there will be absent blood flow. That's how you can differentiate between a bronchogram because of atelectasis from that of pneumonia. Whereas in pneumonia, there is inflammation there. Okay, and this inflammation actually blocks the pulmonary vasoconstriction response. There will be more of blood flow there. Okay, so there you can see along with air bronchogram, there will be pulmonary blood flow also. Why we need to use the color Doppler here is because in pneumonia also there can be static air bronchogram. It's not specific for atelectasis, but dynamic air bronchogram is more seen in pneumonia. Okay. Now, to identify pneumonia, you can use the something called as lung ultrasound scoring along with simplified clinical pulmonary infection score or the SCPIS score. Okay, which include temperature, leukocyte count, tracheal secretions, PF ratio, and color Doppler intrapulmonary shunt. So along with that, lung ultrasound helps to identify bronchopneumonia much more effectively or with much more specificity. So this is what I mean by air bronchogram. You can see these hyperechoic areas inside the collapsed lung. You can see this anechoic area. Anything blank is always fluid. Anechoic structures are usually fluid. Okay, so this is mainly pleural effusion there. Now, we can use ultrasound to differentiate between viral as well as bacterial pneumonia. Okay, mostly in viral pneumonias, you don't get much of consolidations there. Okay, so consolidation air bronchograms are not usually present there. All right, usually, but in COVID patients, in H1N1 pneumonia, ARDS and all, you can have consolidations as well as air bronchograms. Now, in bacterial pneumonias are more likely to have consolidations and air bronchograms. All right. Now, viral pneumonia, the pleural surface is not that destroyed. Okay. The pleural thickening is usually maintained, and there will be smaller bilateral and multiple subpleural consolidation, very small consolidations only. And pathological B lines will be present usually on both lungs, both sides will be involved. Now, bacterial pneumonia usually it involves only one lung, so unilateral consolidation which is larger in size, and you can get air bronchogram. All right, these are rough things only. Now, pulmonary edema, see, its ultrasound is much more superior to identifying pulmonary edema compared to chest X-rays. The hallmark is more than or equal to 3 B lines or confluent B lines. Sometimes there is too much fluid. All these B lines can be confluent. You cannot separate them as distinct B lines. Okay, that's why they are also called as sometimes lung rockets. All right, in one interspace. Okay, now it is because of interstitial as well as alveolar edema, usually bilateral and homogeneous. Now, lung sliding is usually preserved in pulmonary edema. Absence of pleural-like abnormalities, that is something which we can use to differentiate between viral pneumonia or a bronchopneumonia from a pulmonary edema. Okay, the B lines here will be, the pleural line will be much more smooth, whereas in pneumonia, there will be certain breaks in the pleural line. All right. Now, this is the video of B lines. You can see these vertical lines heading from all the top from the pleural line down to the bottom of the screen. Okay. And you can see multiple B lines in one area itself. Okay. You can see there is a confluence of B lines here. That's why the whole area will appear hyperechoic comparing with the other lung here, normal lung there. So B lines actually, you can see that they will abolish or they will cover the A lines. There won't be any A lines there. All right. Now, ultrasound can help us to guide fluid resuscitation in shock patients. So it is included in something called as a false protocol, again put forward by Dr. Daniel Lichtenstein. All right. And what we are looking at is as we give more and more fluids, are the B lines increasing in any particular area? That means there is fluid overload happening. Pulmonary edema is getting worsened. So we can use that to titrate our fluids, or whether we should give diuretics in these patients. Now, bilateral B lines can be present in other conditions like viral pneumonia. So it's not specific for pneumonia, pulmonary edema only. It can be present in viral pneumonias, ARDS, as well as interstitial lung disease. So any condition with increased tissue density or fluid in the lungs, there can be B lines. Now, so the clinical context is actually very important. It can also help us to distinguish between congestive heart failure versus COPD exacerbation. So a COPD patient coming with breathlessness, it may not always be a COPD exacerbation. It could be a pulmonary edema as well. So lung ultrasound is very important. Now, it can also help in spontaneous breathing trial. When we wean a patient off the ventilator and give a spontaneous breathing trial, if there is increase in the B lines, that means the patient is not able to tolerate. The patient could be having underlying cardiac problems, and the risk of weaning failure is high in such patients. Now, ARDS, the finding depends on the severity as well as the stage. Okay, initially in the exudative stage, which is there is more of non-cardiogenic pulmonary edema, there is more fluid in the alveolar interstitial space, and the pathological distribution is also more heterogeneous. You can get bilateral B lines in the early phase. Now, in later phase, it can cause conditions similar to that of pneumonia with consolidation with dynamic air bronchograms and with occasional loss of lung sliding, the presence of irregular pleural line, all these will be seen in the later stage, especially when the fibrosis starts to set in. Now you can monitor the response to your treatment like lung recruitment as well as prone positioning also using lung ultrasound. Now, pleural effusion, it will be seen as an anechoic space. It has a sensitivity of 83 to 100%, specificity from 93 to 100%. What you can identify is something called as the spine sign or the V sign, which is vertebral sign. Okay, as well as there is loss of or the absence of curtain sign. Now, it can have complex appearing septations with echogenic particles if it's an exudative effusion. Okay, exudative pleural collection. Now, there is something called as a plankton sign of floating debris, which is also seen in exudative effusion. Now, you can get something called as a sinusoidal sign or jellyfish sign also. Then effusion depth more than 45 centimeter, it actually suggests you of a volume more than 1000 ml. Okay, so you can say how much volume of effusion is there, whether it's mild, moderate, or massive effusion is there. Let's see a video for that. You can see here in this image, there is an echoic area inside the pleural cavity. Okay, and you can see the lung architecture is now clearly visible because there is no air here. There is water here, which is good conductor of ultrasound waves. You can see the lung structure here much more clearly. Okay, and the curtain sign is absent now. You can see that there is no curtain sign. And what you can see here posteriorly, now this is called as a positive spine sign. All right. Normally, the spine would end at the beginning of the diaphragm because there is air here, which doesn't allow ultrasound waves to reach posteriorly. Okay. But because there is fluid there, it allows ultrasound waves to reach posteriorly. And now you can see the spine, dorsal spine there. All right. So these are the findings you can get in pleural effusion. This lung is undergoing, that part of the lung has undergone compression atelectasis there. Now, what about empyema? How can you differentiate? Empyema, you can get these kind of septations inside the pleural fluid. And this is also called as you can see these kind of floating material, heterogeneous, heteroechoic materials also. That is also seen in empyema. Now, contusion, lung contusion can also be identified using ultrasound. Now, ultrasound has again higher sensitivity than X-rays. V lines are the usual things in the early phase, but sometimes in later phase or in severe contusions, you can get consolidations as well. Now let's come back to the blue protocol. Okay, so a lot of things are there in lung ultrasonography. A lot of findings, a lot of signs are there. All right. Now let's try to make a clinical sense out of them using the blue protocol. First and most important thing, look for lung sliding. If lung sliding is present, look whether it's A profile. A profile means both the lungs are having A lines. Okay. Now, B profile means both the lungs are having more of B lines, pathological B lines are there. Okay. Now, let's see the first thing, B profile. Now, lung sliding is present, B profile is present. That means more chance of pulmonary edema. Both lungs, there are B lines, plus lung sliding is present. Okay. Now, what if it's A profile? There are no B lines there. Both lungs are looking kind of normal. Okay, but the patient is having respiratory distress. Then what you need to do is you need to assess the venous supply in the legs. Okay, the veins in the legs to look for thrombosed veins, which could have resulted in pulmonary embolism. All right. Now, if there are no thrombosed veins there, the veins are looking quite okay. Then the next step is to look at Plapp's point. Remember, in the posterior axillary line, posteriorly, you are looking for Plapp's syndrome. Okay, posterolateral, alveolar, as well as pleural syndromes there. Okay, like pleural effusion, atelectasis, or consolidation there. Okay, like hepatization. All right, those kind of things you are looking. Now, if Plapp's is present, then you think about pneumonia. Pneumonia could be the possible cause of respiratory distress. Now, if Plapp's is absent, that means lung sliding is present, A profile is there. There is no signs of pulmonary embolism. Still, there is a caveat there, all right? Because in diagnosed cases of pulmonary embolism itself, you may not be able to identify a DVT, all right? So that's a possibility. That's why the sensitivity, actually the accuracy of blue protocol is just more than 90% only. It is not 100% accurate to identify any of these pathologies. It's just more than 90%. All right. Now, if Plapp's point is also not there, that means the lungs look pretty much normal. It could be a COPD exacerbation or an asthma exacerbation. For that, you need to auscultate for V's. All right. Now, the next profile, what you need to be knowing about is the AB profile or C profile. Lung sliding may or may not be present. AB profile means that one lung is having A profile, there is no B lines, whereas the other lung, there is B lines. So there is one-sided B lines is there, all right? Or it could be C profile. C profile means that anteriorly there is consolidation in one lung. Okay, all these things are suggestive of pneumonia. So lung sliding may or may not be present, but there is B lines in one lung. Okay, then all consolidation is there anteriorly in one lung. That is also suggestive of pneumonia. All right, now let's look at this arm here. Lung sliding is absent. Okay, so that includes either A prime profile or B prime profile. Prime addition of this prime suggests that there is no lung sliding. Okay, so lung sliding absent, but there are B lines there bilaterally. This could be again pneumonia. It could be a viral pneumonia or any other pneumonias. All right, it could even be an ARDS condition. Okay, now A prime profile means A lines are present, but there is no lung sliding. Now you need to think about pneumothorax, right? So if lung point is present, definitely it's pneumothorax. But without lung point, you need other diagnostic modalities also. Okay, so that's about blue protocol. Okay, sometimes you might need X-rays, sometimes you might need CT thorax to identify what's further condition there. Okay, so lung sliding absent, and you are getting a profile there. Without lung point, you need further imaging. Okay. Now, let's come back to this arm where you need to evaluate for thrombosed veins. So how do you do bedside DVT screening? All right, this is very important. Mainly, we are looking at the large veins for clots, okay, for thrombosis. This includes the femoral vein as well as the popliteal vein. We are not looking at the calf veins because the thrombosis from there and embolization is not big enough to cause an obstructive shock there. Okay, it can cause subsegmental PEs, but not severe enough to cause a significant pulmonary embolism. Okay, so we are mainly looking at the femoral vein as well as the popliteal vein. Now, it has a sensitivity of 96% and specificity of 97%. What we are doing is something called as a compression ultrasonography. Okay, we are doing a screening compression ultrasonography. And studies have shown that it is as accurate as traditional duplex as well as triplex vascular ultrasound examination done by radiologists. All right. Now, compression ultrasound exams, we are doing at two sites, the common femoral vein as well as the popliteal vein. Okay. Now, arteries are generally, but the main challenge here is to differentiate veins from the arteries. So the arteries are generally rounder, thick-walled, pulsatile, and smaller compared to the larger veins. Veins are usually fully compressible even with light pressure using the transducer, whereas arteries require substantial pressure to completely compress. Now, you can also use color flow Doppler. Okay. Now, how it can be done is by using the Doppler in a horizontal manner and facing it towards the patient's head end. Now, venous flow will appear as blue. Okay, remember the mnemonic BART. Blue means away from the probe. It's moving, the blood is moving away from the probe. It doesn't mean that it is venous. Okay, but if you keep it in this orientation, blood moving away from the probe, it is venous. All right, and BART, R is for towards the probe. Whichever blood is moving towards the probe, it is red in color in Doppler examination. So that's also another way you can identify veins from or distinguish veins from arteries. Now, these are the main points. Mainly 5 points have to be examined for compression ultrasonography. First one is at the junction, or it's at the common femoral vein just below the inguinal ligament. Okay, you can see the common femoral vein here. And the next point is at the bifurcation or the branching of the great saphenous vein. These branches are more likely to have thrombosis. The third point is at the branching of the lateral perforator here. The fourth one is at the branching of the common femoral into the deep femoral as well as the femoral vein. Okay, there is no superficial femoral vein. The continuation is called as the femoral vein, giving off a branch of the deep femoral vein. Okay. Now, the femoral vein continues here as the popliteal vein. So that's the fifth point, which is at the popliteal fossa. Now, this is how you are doing compression ultrasonography. You can see the various structures here. This is at the bifurcation of the great saphenous vein. Here, it's going to divide into, there is branching of the lateral perforator here. Here, there is deep femoral vein as well as femoral vein. Going further down, you can see the femoral vein there. Okay, and this is how you examine the popliteal vein also. The popliteal vein is usually seen superficial to the popliteal artery. Okay, now here you can see an image of a thrombus there. Here, without compression, in the common femoral vein itself, you can see a echogenic structure inside the vein. This is a thrombus. To confirm it, you do a compression test. Okay, you compress it lightly. You can see that the vein is not completely collapsible. Normally, it should be completely collapsible, such a way that you will not be able to see the vein at all. All right. Now here there is a thrombus in the popliteal vein, and again by compression you cannot compress the vein. Okay, this is the compression ultrasonographic examination for DVT. Okay, there are some caveats here. In many of the cases, you may not be able to see a echogenic thrombus inside. It depends on how old the thrombus is. Okay, acute thrombus, sometimes you may not be able to see. Only by compression, you will be able to identify. All right, so that was the blue protocol. Okay, and using that, we were able to identify or rule out the conditions. We can rule out the conditions which can cause respiratory distress or respiratory failure in this kind of patients. All right, now let's move on to the shock part. Okay, we'll finish off the shock part pretty quickly. All right, and the things which we have to consider for the shock are the possibilities again in this patient include septic shock, hypovolemic shock, obstetric shock, or even cardiogenic shock. All these are possible in these patients. Okay. All right. So let's move on. Now, how can ultrasound help us to identify or to differentiate which type of shock is involved in this patient? Or can it be a mixed shock also? Very much possible in this patient, right? So there is a protocol which is very commonly used, something called as the rush protocol, which is a rapid ultrasound in shock. Okay, this is mainly for undifferentiated shock. We don't know what is the underlying cause for the shock. We want to find out which type of shock it is. You can use something called as the rush protocol. There are a lot of other protocols also, like the Falls protocol, ACES protocol, Beats protocol. But this is the most commonly one as well as the most famous one also. Okay. Now, in the rush protocol, you have to scan all these areas. All right. You can remember the areas to be scanned as heart, the structures which should be scanned as HIMAP, HIMAP. All right. H is for heart, I is for IVC, M is for the Morrison space, all right, which mainly includes the fast examination. A is for aorta, and P is for pulmonary examination. HIMAP, remember, heart, IVC, Morrison space on the abdomen, aorta, and pulmonary. Okay. So what we are actually looking for is actually these things. This is the protocol. We are mainly looking at something called as the tank, the pipes, as well as the pump. All right. The heart is the pump. The tank is the vascular or the volume. Okay, patient's volume status of the patient. Then finally, the pipes which distribute blood to all parts of the body. Main pipes are the aorta as well as the main veins like the femoral vein to look for any obstruction in these veins there. Okay, we will come to this algorithm again. All right, but everything starts with the heart. The first structure which we are going to look at is the heart. So you need to know how to perform bedside echocardiography. All right, you don't need to know advanced echocardiography to diagnose these critical conditions. These all are included in the basic echocardiography. All right. So what kind of probe we are using is phased array probe to look between the ribs to see the heart there. So it has a frequency of 2 to 5 hertz, megahertz. Now, basic views are basically 5 views are required. These include the parasternal long axis view or PSL view, then parasternal short axis view or PSS view, then apical four-chamber view, subcostal long axis view, and finally the inferior vena cava long axis view. These are the 5 views which is basically which you need to get. First one is the parasternal long axis view, PSS, PSL, or sometimes called as the plaques view also. Okay. Now here you are actually cutting the heart in this manner using the ultrasound rays. All right. And you are going to get an image like this. This is the right ventricular outflow tract. This is the left ventricle, left atrium, the aorta. This is the aortic valve here, and this is the mitral valve there. And this hyperechoic structure here, this is the pericardium. All right. Now, the utility of parasternal long axis view, you can see very well, have a qualitative estimation of the ejection fraction. You can see the right ventricular outflow tract, then left ventricular wall thickness as well as function can be assessed. You can use it to evaluate the aortic valve as well as the mitral valve. You can look for the functions of these valves as well as evaluate for septal kinetics. Okay, the movement of the septum, whether there is any radial wall motion abnormality there. Then left atrial chamber size can also be seen. All right, then you can see the descending aorta here. So you can look for any aneurysm there, any dissection there. And finally, the pericardial space. Okay. Now, what are the pitfalls of the parasternal long axis view? You cannot assess the right ventricular size. What you are seeing is the right ventricular outflow tract. The entire RV free wall is not at all seen. Now, inaccurate LV size and function, if you are using not in the proper axis, if you are not holding it, if it is slightly in the off axis itself, you can underestimate the left ventricular size and function. Then inaccurate assessment of mitral valve as well as AV function, again, if it is in the off-axis plane, all right? And finally, pericardial and pleural effusion, sometimes it can get confused. Now, this is the parasternal short axis view where you are actually rotating the probe by 90 degrees, where the probe marker will be facing the left shoulder. In the parasternal long axis view, the probe marker will be facing the right shoulder. Okay, now from this view, we are going to rotate it so that we are going to cut the left ventricle in its cross section. Okay, so you will get this kind of view there. All right, and this is the anterior wall, this is the inferior wall. These are the papillary muscles. This is the mid-cavitary level or the papillary muscle level, okay, of the left ventricle. This is the androseptal wall here, and this is the androlateral wall here. Okay. Now again, this is an image showing the same here. You can see the left ventricle in its cross section. The right ventricle also in its cross section can be seen. It is usually seen as a crescent shaped structure, the right ventricle here. And you can see the different walls here. All right. So this is the main view where you are looking for regional wall motion abnormalities. So you can see the anterior wall, androseptal, septal wall, inferior wall, posterior wall, as well as the lateral wall at the level of the papillary muscles. So utility, it can also be used to qualitatively estimate the ejection fraction, RV and LV wall thickness, LV segmental wall function, chamber size as well as function, septal kinetics, then pericardial space also can be seen. Okay, now the pitfalls again off-axis views, inaccurate estimation of LV function, LV configuration, as well as the sizing is not always possible. Okay, here you can see the RV is not completely seen. RV free wall is not always fully seen here. So sizing of RV is also somewhat difficult. Next one, and the most difficult view to obtain, is the apical four-chamber view. All right, and this is obtained by keeping the probe in the apex itself, and the probe marker should be facing towards the right side, slightly towards the right shoulder. Okay, here you can see all 4 chambers here, and the septum, the marker, the probe should be placed in such a way that you are aligning the septum horizontally in the midline there. All right. Vertically in the midline there. And you can see the LV, LA, as well as RV, as well as RA, as well as the valves there. Now, utility, qualitative assessment of ejection fraction, RV and LV wall thickness, LV segmental wall function, all these things are there. Pitfalls, it is most difficult to view. Off-axis image can result in erroneous measurements. Now, this is the fourth view. This is subcostal long axis view. This view is especially very useful to identify the right ventricle also. Okay, you can estimate the right ventricle wall thickness to identify whether it's a chronic pathology like chronic pulmonary hypertension conditions using this view. This view also is useful in COPD patients with hyperinflated lungs where you are not able to see any other views, but only the subcostal view is acceptable. Patients on ventilators with high PEEP also, this view is most useful. All right, the utilization. And one more important thing is during CPR, because chest is being compressed over the sternum, you can use the subcostal view to identify any cardiac pathologies. Now, the fifth view is to view the inferior vena cava. All right. So this is again using the phase direct probe, or you can use the curvilinear probe with the marker pointing towards the patient's head. Okay. Now, important thing is that you need to trace it or differentiate it from the aorta. So always try to trace the IVC cranially such a way that its entry into the right atrium should be seen here. Okay, and also you can see the middle hepatic vein also draining into the IVC. So that's the ideal view you should be getting to differentiate it from aorta. And aorta is pulsatile and slightly more towards the left side of the IVC. Now, LV systolic function, how can you estimate that? Now, we have seen the different views which we need to obtain. Now, we need to see how to estimate the LV systolic function, whether the heart is beating normally or is it a cardiogenic shock? All right, that's how we need to differentiate. Now, we can use different methods. First of all, three things which we are utilizing is something called as the endocardial excursion, myocardial thickening, and finally something called as the EPSS, which is E-point septal separation or septal motion of the anterior mitral valve leaflet. Okay, we are simply calling it easily, we are calling it as EPSS, E-point septal separation. Okay, so what do you mean by endocardial excursion? You can see in the Planck's views, both these walls, the endocardium should approximate each other towards the middle. Okay, so they should come by at least 30 to 40% towards the middle. That is called as endocardial excursion. That is suggestive of good LV systolic function. All right. Now, myocardial thickening means during systole, the myocardial wall should increase its thickness by at least 40%. Now, septal motion of anterior mitral leaflet or EPSS is estimated by looking at the anterior leaflet of the mitral valve. Normally, during systole, okay, it should go, normally during diastole, it should go and almost touch the septum here. All right. During the early phase of diastole, when the mitral valve opens, it should go and almost touch the septum there. Okay. Now, you can divide based on your findings of these three things. You can divide the heart as normal LV systolic function, or it could be hyperdynamic, or it could be reduced, or even severely reduced. Okay, let's see a video of myocardial excursion. This is mainly by something called as eyeballing method. We are not quantifying any of these measurements. Okay, we are not estimating the ejection fraction using the Simpson's method or any other method. We are using the eyeballing method, which is a qualitative method. But studies have shown that it is as good as any other method of ejection fraction estimation. Okay. Now, you can see that the endocardial walls are coming towards the midline by at least 40%. This is normal myocardial excursion or endocardial excursion. All right. Now, this is a poor myocardial excursion. Okay, you can see the walls are wide apart. They are not coming together by at least 40%. Okay, so this is severe systolic dysfunction. You can compare both these views. All right. Next one is looking for myocardial thickening. Okay, you can see this video. This is the parasternal short axis view. You can see the entire myocardium of the left ventricle is coming towards the center like this during systole. Okay. And you can see the walls of the myocardium is getting more thickened during systole. All right. Now we will see an example where there is no good myocardial thickening. This is suggestive of LV systolic dysfunction. Now, what do you mean by EPSS or E-point septal separation? Okay. Now, the normal value should be less than 0.7 centimeter or 7 millimeter. Okay. Now, LV function is moderately depressed if it is between 0.7 to 1.7 centimeter, and it is severely depressed if it is more than 1.7 centimeter. Now, what do you mean by EPSS? We will see. So, a low EPSS is actually suggestive of high ejection fraction. All right. Now, what we are basically looking at is this structure. This is the anterior leaflet of the mitral valve. During diastole, it should go and almost touch the septum there. The more closer it comes to the septum, it actually doesn't touch the septum, but the more closer it reaches to the septum, that means the LV systolic function is that much better. All right. So it should be ideally less than 0.7 centimeter, the distance between the tip of mitral valve as well as the septum here. Now, how can you measure that? You can use the eyeballing method, or even if you can quantitatively measure this. Okay, so this is the point of interest there. Okay. Now let's see the qualitative method. Here you can see, just by looking at it, you can see that the tip is going and almost touching the septum. This is good LV systolic function. All right, definitely more than ejection fraction is more than 40 to 50% here. All right. Now, how you can measure it actually is by using the M mode. So you mark this M mode line, all right, this line, you place it along the mitral valve tip, anterior leaflet tip of the mitral valve. Okay. And in the M mode, you can see these sort of waveforms. So this is the actually E point, the opening of the mitral valve here, because of the early diastolic phase when there is rapid flow into the ventricle, there is this E point there. And the second point here is actually because of the atrial kick. Okay, atrial systole happening. There is more blood coming into the ventricle. There is a second opening of the mitral valve. That is seen as a point here. So this is the E point and this is the A point. What we are measuring here, see, this is the septum. All right. We are taking cut here. So here, this is the superficial structures, two superficial tissues there. And this is the RV. Okay. Same here as RV. This is the right ventricle here. And this is the septum here. So this is the septum here, which is seen as septum here in the M mode. And this is the LV, and this is the mitral valve. Okay. So we are taking the difference or distance between the tip of mitral leaflet here and the septum. You can see it's almost touching the septum there. All right. So the EPSS is actually less than 0.7. So the ejection fraction is very good here. Okay. Let's move on. But there are some pitfalls, all right? Some conditions there can be falsely high EPSS suggestive of a low ejection fraction. These include mitral stenosis. So the LV ejection is actually normal, but because of mitral stenosis, the valve is not able to completely open and reach the septum there. Other condition is because of severe severe aortic regurgitation, where the regurgitant jet is actually pushing the mitral leaflet from touching or reaching the septum there. All right. So those two conditions can give falsely high EPSS and a low ejection fraction. Now, falsely low EPSS can be seen if you are not using the proper axis for evaluating these functions. Now, what do you mean by a hyperdynamic heart? Now, we learned how to assess the ejection fraction. We know how to identify poor ejection fraction or low ejection fraction. Now, what do you mean by hyperdynamic heart? This is seen Now, this happens with ejection fraction of more than 70%, usually seen in conditions where there is hypovolemia. All right. So, as a compensatory mechanism, there is tachycardia, increased cardiac output by increasing the catecholamine surge there. Okay. So, the walls will be the ventricular walls will be squeezing so tightly that the walls will be almost coming and touching each other. All right. In the parasternal long axis view, it's sometimes called as the kissing LV sign. All right. In parasternal short axis view, you can see that the papillary muscles are almost coming and touching each other. Okay. But very important thing, don't think this is just because of tachycardia. This is usually seen in hypovolemic shock. It can also be seen in other conditions like anemia, high output cardiac failure like thyrotoxicosis or anemia. You can see here the parasternal short axis view, the papillary muscles are almost touching each other. This is a hyperdynamic LV. Here also, it's a slightly off axis view, but still you can see the LV walls are almost kissing each other. This is a kissing LV sign suggestive of hyperdynamic heart, usually seen in hypovolemia or in sepsis also you can get this finding. All right, there is relative hypovolemia also there. Now these are the different images or videos for the hyperdynamic heart, normal heart, as well as a depressed heart. You will get familiar with these images as you see more and more of these kind of images. Now, next is how to evaluate for regional wall motion abnormality. That is also an important function of bedside ultrasound. Okay. Now, in this video, you can see that, there isn't endomyocardial excursion here. Okay. The septum is kind of hypokinetic there. So, there is mid-anteroseptal hypokinesia in this patient. And in the parasternal short axis view, you can see that the anterior as well as the anterolateral and anteroseptal walls are not moving that much. Okay, so that is again regional wall motion abnormality. It could be because of a myocardial infarction in the LAD territory. Okay. Here again, you can see the apex is not moving. The septal part as well as the lateral wall is not moving that well. This is regional wall motion abnormality. Okay. And finally, the utilization of ultrasound is also for echo, you need to look at pericardial effusion. And if there is an effusion, is the tamponade there? All right. You can see here, there is pericardium here. All right. And there is a large collection of fluid around the heart inside the pericardium. Okay. And you can see, I'm not sure if you can make out the descending aorta here. Okay. The pericardial fluid is splitting the heart from the descending aorta. That's how you can differentiate it from pleural effusion. Pleural effusion will be seen below the descending aorta, whereas pericardial effusion will be seen between the heart and the descending aorta. All right. Now, how do you know if there is tamponade there? The sign which you are looking for tamponade is something called as the RV diastolic collapse. All right. RV collapses during diastole when it actually should be expanded. Okay, that's a sign of tamponade effect there. And in addition to that, you can look at the IVC also. The IVC also will be distended if there is tamponade effect there. IVC will be distended and plethoric with poor respirophasic variation. Next structure which we need to identify in echocardiography or assess in echocardiography is right ventricle. All right, because in our shock rush protocol, we need to identify whether there is evidence of pulmonary embolism, whether it's an obstructive shock. Okay, tamponade can also result in obstructive shock. Another condition which can result in obstructive shock is pulmonary embolism. Another condition which can result in obstructive shock is again tension pneumothorax. Okay, so how to assess the right ventricle? In these all four views, you can assess the right ventricle. All right, there is something called as the 1/3 rule, where the right ventricle size will be equal to that of the ascending or the root of the aorta as well as that of the left atrium. So all these will have 1/3, okay, which will form the entire structure here, the base of the heart here, okay, in parasternal long axis view. In short axis view, you can see RV is usually a crescent shaped structure. All right. So this can be used to see if there is any bulging of the septum, if there is any pressure load in the RV, which can result in flattening of the septum or bulging of the septum into the left ventricle. Now, apical four-chamber view can be used to see the entire RV cavity as well as the free wall. Okay, it can be used to assess something called as TAPSE. We will see what TAPSE is. Okay, and finally, to assess the RV wall thickness, for example, in chronic core pulmonary conditions, you can use the subcostal four-chamber view. Now, normal RV is less than two-thirds the size of the LV size, or less than 60% of the left ventricular size. Now, if it is moderately dilated, see, we know that RV, in RV dysfunction, RV infarction and all, it tends to dilate easily. Okay, in acute conditions as well as chronic conditions, it tends to dilate easily. But in chronic conditions, along with dilatation, you can see increased in the RV wall thickness. All right, that's the difference between acute and chronic conditions. Now, in moderate dilatation, there is moderate dysfunction of the RV. When RV size is more than two-thirds of the LV size or almost equal in size that of the LV. Now, it's severely dilated as well as severe dysfunction is there if RV size is more than that of the LV size. You can see here, this is the RV compared to the smaller LV here. Okay, again, you can see when there is increase in the RV pressure also, there is bowing of the septum into the left ventricle, along with increase in size of the right ventricle compared to the LV. In short axis view, you can see something called as the D sign here. Okay, RV is so much distended, there is so much increase in pressure there, it moves the septum into the left ventricle. Okay, it changes the shape of the septum there. Now, this is a video showing the D sign there. RV is dilated here, and you can see during systole, the LV is in the form of a D here. Okay, this is called a D sign. So during systole, there is so much increase in the pressure in the right ventricle. Okay, so that's the D sign. Now, what do you mean by TAPSE? TAPSE is tricuspid annulus plane systolic excursion. Now, this is another method for evaluating the RV function. Okay, now in this video, you can see that this is the RV and this part here is the tricuspid annulus there. Okay, and you can see that it's moving very much towards the apex. RV contractility is more longitudinally towards the apex. Now, to identify how much or quantify the TAPSE, what you can do is you can put an M mode here, okay, along the tricuspid annulus, along the RV free wall here, okay. And what you are seeing is a movement of the annulus towards the apex, like this kind of movement there, which will be seen over here. Now you can measure how much the tricuspid annulus is moving. Okay, you can measure it using calipers. All right, from the peak here, okay, we can use this one from the peak here to the valley here. Okay, so normal is more than 17 millimeter. All right, less than that is abnormal. That means there is RV dysfunction. Okay, it could be because of RV strain. Now, another sign to suggestive of RV strain and indirectly suggestive of pulmonary embolism is something called as McConnell sign. This is also very important. Okay, McConnell sign is that only the RV apex will be beating. There is a kick in the RV apex. The mid as well as free right ventricular wall is not at all. It's not at all working, or it is hypokinetic along with the dilated LV. This is called as McConnell sign. RV apex is the only part which is contracting. Okay. So these are the different things you need to look for in the right ventricle. The right ventricular size, the RV shape, RV wall thickness, interventricular septum, RV systolic function using TAPSE. Then you can also actually estimate RV systolic pressure, which is a little beyond the scope of this talk. Okay. Now coming back to the rush protocol, now we have looked at the heart as well as the IVC, right? Okay, no, sorry, we have looked at the heart. Okay, so this is the heart view, parasternal long axis, short axis, as well as the apical four-chamber view. All right, these parts we have covered. Next is the IVC, how to evaluate the IVC and how to interpret the findings there. Now, inferior vena cava. All right. Now, the importance of assessing the inferior vena cava is mainly to assess the volume status, whether we can give fluids in shock, and what we are basing it is on the respirophysic variation of the IVC. What it means that the IVC usually collapses during inspiration and it expands during expiration. This is called as respirophasic variation because we know during inspiration, more of preload goes into the ventricle, into the heart. Okay. Now we can estimate that by using something called as the Cavell index, which actually suggests the preload reserve. Now all the studies, what they have done is they have tried to identify the IVC diameter, its collapsibility with respect to CVP. Okay. So that's how the studies have been. Now, how to measure the IVC? You can use any probe. Maybe we are using the phased array probe itself. Now, important thing is that when you're measuring, it shouldn't be close to the heart here. See, you can identify IVC entering into the right atrium, but if you take a point anywhere near the heart, there can be some false effects from the intrathoracic pressure. To avoid that, we are actually using a point. See, this is the entry or the drainage point of the middle hepatic vein. So slightly distal to that. Some books are saying 2 to 3 centimeter distal to the entry of the middle hepatic vein. Okay. Some books are saying just 2 centimeter distal to the entry of the IVC into the right atrium. Okay. Now you are using the M mode at this point here. And you can see that in the M mode, actually, this is the point of inspiratory collapse, and this is the expiratory expansion of the IVC. All right. So again, that's the middle hepatic vein there. Okay. Now, here you can see this is in the expired phase, the maximal diameter, and this is during the inspiratory phase, the minimal diameter. Now, Cavell index is obtained by calculating the maximal IVC diameter, which is the expiratory one, minus the minimal inspiratory diameter divided by the maximal IVC diameter. In these all kinds of these indexes, always it's better to remember like maximum diameter minus minimum diameter by maximum diameter. So in spontaneously breathing patient, in these kind of patients, maximal diameter is during expiration and minimal diameter of the IVC is during inspiration. Now it changes if this patient is being mechanically ventilated. That's why I'm saying. All right. Okay. Now, this is what I have been saying. Now, it's equated with CVP in many of these studies. Okay, so what you can see here is that if the IVC is less than 1.5 centimeter and the Cavell index is more than 50%, that is, it is more than 50% collapsible during inspiration, then the CVP is anywhere between 0 to 5, and you may consider giving these patients fluids. Okay, if they are in shock, you may give IV fluids. Okay, because the chance for cardiogenic shock is less likely. Now, in these patients, if it is between 1.5 to 2.5%, and if Cavell index is more than 50%, again, CVP will be somewhere between 6 to 10. Again, you may give some fluids and see the trend in the IVC. Now, if it is between 1.5 to 2.5% and less than 50% collapsible, the CVP is much more higher. And if the IVC is more than 2.5 with little or no change, then the CVP is much, much higher. Okay. Then in such cases, you may consider not giving fluids in these patients with shock. Okay. Now, this is how a plethoric IVC or a dilated IVC looks like with minimal inspiratory or respirophasic variation. Okay. Now, what are the indications for IVC ultrasonography? To measure the CVP, and it's an indirect measure of CVP, which we have already seen in spontaneously breathing patient. Then to look for pericardial effusion, okay, whether there is tamponade or not. So if you see pericardial effusion and IVC is distended, there is tamponade effect. If it is not distended, there is unlikely to be tamponade. Now, right heart failure, Dilated IVC is also seen in cor pulmonale and severe tricuspid regurgitation. So in these kind of patients, it cannot be used to infer CVP or volume responsiveness. So that is one caveat or one pitfall of using IVC. If there is in COPD patients with cor pulmonale or severe TR, IVC is not reliable. Then device placement, for example, ECMO catheters as well as femoral transvenous pacemakers, you can use IVC visualization. Then finally, volume responsiveness, as I already mentioned, with all its caveats, it has limited utility. Now, I already mentioned there is a difference in ventilated patients. See, in ventilated patients, we are using not collapsibility index because there is positive intrathoracic pressure. It will naturally tend to distend the IVC. All right. So what we are using is something called as IVC distensibility index. But be careful if you are using this index, the patient has to be passive. That means the patient shouldn't be spontaneously breathing even on the ventilator. The patient shouldn't have any arrhythmias. And the patient should get a minimal tidal volume of around 8 ml per kg. Okay, so those are the conditions under which you can use IVC distensibility index. Again, how it is diagnosed, how it's calculated is by using IVC maximal diameter minus minimal diameter divided by maximal diameter. But remember here everything is changed. Okay, here the maximal diameter or IVC gets distended during inspiration because it's positive pressure during inspiration. IVC gets distended during inspiration. Okay, so the maximal diameter here during is the inspiratory diameter, which is opposite to that which we used for collapsibility index. Now, if it is greater than 12 to 80%, that suggests there is good respirophysic variation and these patients might be volume responsive. So that's about the heart as well as the IVC. Next, coming to the Morrison's space, which essentially suggests to look for intra-abdominal bleeding. All right, so we have to do a fast scan. We have to examine the right upper quadrant, left upper quadrant, as well as the suprapubic views. Okay, actually the fast scan also includes a pericardial view, subcostal view, but we have already done that while evaluating the heart. Okay, now what we are looking for is free or intraperitoneal fluid, which appears anechoic or black in the Morrison space. So the space between this potential space between the liver as well as the kidney on the right side. All right. So if there is black color here, okay, especially towards the caudal tip, that area must be always visualized. First, fluid collects in the caudal tip. In a supine patient, the most dependent area is the Morrison's pouch. That's why we are targeting the Morrison's pouch initially. Okay, so even with about 100 ml of fluid, you can get positive FAST examination. FAST is focused assessment using sonography in trauma. We will see that in detail when we are seeing ultrasonography in trauma patients. Okay, then in the left upper quadrant, we are mainly seeing the subdiaphragmatic area or the penisplenic area. That's where fluid tends to collect. In the suprapubic area, any fluid, anechoic area around the bladder. Then finally, in hemothorax, okay, that's another area in E-fast, all right? Now, you can roughly estimate the volume of fluid or blood in hemothorax, all right? You measure the largest pocket here from the diaphragm there. Now, for example, if it is 80 millimeter, you multiply it with 20. Okay, so 80 into 20 is 1600. That much ml of fluid is collected there. All right. Now, if it is more than 1500 ml, that is an indication, more than 1500 ml draining initially itself, that is an indication for thoracotomy, right? So you are basically looking at any leak in the tank here. Okay. The next area to be scanned is actually the aorta. Okay. In the aorta, what we are actually looking for is aortic syndromes like aortic aneurysm is there, abdominal aortic aneurysm, which can rupture, then aortic dissection. Those are the things which will also we will see along with case discussion of abdominal pain. Now, finally, the pulmonary area, we are mainly looking for tamponade. Sorry, we are mainly looking for tension pneumothorax. Sorry about that. Okay, which we have already seen. All right, so let's see the protocol again once more. The heart, IVC, Morrison's pouch or fast examination, aorta, as well as the pulmonary area. Okay. Now, here, first of all, the heart, what we want to see is that, is there any pericardial tamponade? Is there any cardiac tamponade? So, is there any pericardial effusion? Is the IVC distended? All right. Is there any RV diastolic collapse? If there is pericardial tamponade, that is the reason for the obstructive shock there. You need to do pericardiocentesis. Okay. Now, the next thing you need to look for is RV, right ventricular dysfunction. Is the RV dilated? Is the TAPC reduced? All right. Is there any D sign or any McConnell sign? All right. That would be suggestive of a pulmonary embolism. It could be obstructive shock from severe pulmonary hypertension or a massive pulmonary embolism. All right. So we initially looked at fluid around the heart. Then we are looking for RV strain pattern there. Then we are looking for the LV systolic function. Okay, we know by looking at the endocardial coming together or the myocardial thickening or the EPSS, you can assess the ventricular dysfunction. All right. Now, if there is left ventricular dysfunction, again, you can look at the IVC. All right. Now, if the IVC is very much distended, the reason for shock is again cardiogenic shock because of poor LV systolic function. Now, if the IVC is normal or collapsing, it's less likely to be a cardiogenic shock. Okay. Now, again, if the heart is normal or hyperdynamic, so these are the four conditions which we are looking for the heart. All right. Now, if the heart is normal or hyperdynamic, then you need to look for volume loss. Okay, it could be because of dehydration or GI loss, or it could be because of leak in the tank. Somewhere there is a leak in the tank, like there is free fluid in the abdomen, like fast positive, there is free fluid in the abdomen. It could be an intra-abdominal bleed from a trauma maybe, or in female patients in the reproductive age group, it could be because of a ruptured ectopic pregnancy. Those kind of things can happen. Then we are looking at the pipes, mainly the abdominal aorta for any aneurysm there, because it could be a AAA rupture, especially in elderly patients with hypertension, coming with abdominal pain and in shock, as well as with pallor, always suspect AAA rupture. All right. Okay. Next, let's come back to this. Okay. Now, if there is other thing which you need to look for, apart from the heart, IVC, Morrison's pouch, and the aorta, is the pulmonary area. So look for lung sliding there, plus or minus lung point. Okay. If lung sliding is absent, there is a lung point there. It could be because of a tension pneumothorax. So that's how we are evaluating using the high map protocol. All right. So we are looking at the tank, which is mainly the heart, how well the tank is. Sorry, we are looking at the pump. I'm extremely sorry. We are looking at the pump first initially, which is how good is the pump working? Is there any RV strain? Is there any fluid around the pump? All right, those kind of things we are looking first. Then we are looking whether there is any obstruction or any leak in the pipes. All right. So leak in the pipe could be aortic aneurysm rupture. There could be mm, there could be obstruction in the pipe, like a pulmonary embolism there. Then finally, we are looking for the vascular status. How full is the IVC? Okay, if there is hypovolemia and LV is hyperdynamic, IVC is collapsed, there could be hypovolemic shock, right? So those are the different things to consider. All right. Now, if none of these things are there, always consider in a hyperdynamic heart, it could be sepsis, anaphylaxis, toxins or drugs could be there, or it could be hypovolemia because of dehydration. Okay, so that's about a rush protocol. Now, there are other protocols also in shock, which includes the false protocol. This also again put forward by Daniel Lichtenstein and team. First of all, ruling out obstructive shock, as we have already mentioned, do simple cardiac echo, see if there is any pericardial tamponade and whether there is right ventricular dilatation. Okay, so then go for blue protocol, assess if there is A prime profile. All right. So we are looking for cardiac tamponade, pulmonary embolism, as well as tension pneumothorax. After ruling out the obstructive cause, rule out cardiogenic causes. All right. Mainly look for pulmonary edema along with the blue protocol. Look for B profile. That means B lines on both lungs. Okay. Along with a distended IVC, it could be a cardiogenic shock. All right. Now, ruling out hypovolemic shock, correction of parameters of shock under fluid administration. Look if the IVC is completely collapsed, as well as any signs of bleeding is there. All right. And give fluid boluses and see the response. The lungs will be normal initially there. Okay. Now, finally, detecting distributive shock or septic shock currently, fluid therapy not able to improve the circulation, eventually generating a B profile. So initially there will be A profile. Now after giving fluids, there is B profile there. Okay. Now, what is the role of ultrasound or point of care ultrasonography in cardiac arrest? Now, in cardiac arrest, like I also already mentioned, we are usually going for the subcostal view. The main, first of all, the thing is to look whether there is cardiac contractility, whether there is any LV systolic function. Because in cardiac arrest itself, it can be true PA or a pseudo PA. A true PA means that there is no LV contractility. There is electromechanical dissociation. You can get ECG waveforms, but LV is not at all working. All right. But in certain conditions like severe hypovolemia, cardiac tamponade, tension, pneumothorax, or massive PE, there can be sometimes pseudo PA, where the heart is pumping, but the blood pressure is so low because of hypovolemia or obstruction. You are not able to get a pulse and the patient is in cardiac arrest. So the first thing that you look for is whether the heart is working or not, heart is pumping or not. The second thing that you can look for is the other pathologies or the reversible causes of cardiac arrest, like cardiac tamponade or tension pneumothorax. All right. Here, again, look whether there is any fluid in the pericardial space, whether there is any RV diastolic collapse, is the IVC distended. All right. In that cases, during cardiac arrest, during CPR itself, you can do pericardiocentesis. Now, look if there is contractility, cardiac contractility, but there is absent lung sliding on any one side. It could be because of a tension pneumothorax, along with other clinical signs like tracheal deviation, distended neck veins, absent breath sounds on one side. It could be a tension pneumothorax. You can relieve it by needle thoracostomy followed by ICD insertion or a finger thoracostomy. Okay. Okay, so those are the different applications of actually bedside ultrasonography or POCUS during cardiac arrest. Now, if the patient is having prolonged cardiac standstill with blood clots inside the heart, then that is one of the indications where you can stop your CPR efforts. Next, this is the final topic. What is the role of transesophageal echocardiography? All right. We are not going into the details of this thing, but certain minor things you need to know. What are the indications, contraindications, what are the views which are used. All right. Now, this is much more accurate for getting good windows, high imaging quality compared to transthoracic echo, which we discussed till now. All right. Now, point of care TE has unique value in cardiac arrest, where it can help in the diagnosis, management, as well as prognosis without interfering or interrupting the CPR quality. Because subcostal view is also sometimes difficult to get in these patients while CPR is ongoing. There can be moments which can help, which can make it difficult for us to assess the LV function, whether there is fluid there, we might be in doubt there. Okay. And sometimes patients can be in ventricular fibrillation also. Fine ventricular fibrillation, monitor might be showing, we might mistake it as asystole. But in transesophageal echography, you might be able to see the ventricular fibrillation happening. Fibrillating muscles might be able to be seen. Okay. So it is much more useful in cardiac arrest also compared to transthoracic echo. So these are the basic as well as advanced indications. Basic indications for shock, cardiac arrest, volume status assessment, then pericardial effusion assessment, then in severe valvulopathy also it's useful. Advanced applications usually it's not done by us, usually done by cardiologists. Advanced hemodynamic assessment, procedural guidance for ECMO, pacemaker, line placement, then endocarditis evaluation, advanced valvular assessment, acute aortopathy like aortic dissection, especially in the thoracic region of the aorta, perforated foramen ovale or shunts, then cardiac source for embolism like left atrial appendage. It's much more easily seen in the transesophageal echo. Then what are the contraindications to TE? Absolute contraindications, any GI pathology, dangerous GI pathologies like perforated viscous or activated upper GI bleeding with recent upper GI surgery also. Those are important things. Then esophageal pathologies like stricture, tumor, perforation, diverticulum, esophagectomy, then recent esophageal surgery. These are absolute contraindications. Then relative contraindications can include other GI pathologies like recent upper GI bleed, peptic ulcer disease, esophagitis, dysphagia. Then esophageal pathologies like Mallory Weiss tear, scleroderma, esophageal varices. Then cervical spine disease like atlantoaxial joint disease, severe arthritis, prior head, neck, chest radiation, coagulopathy, thrombocytopenia. These are all relative contraindications. Then complications are very, very little. All right. Main complications are oropharyngeal injury related. Esophageal injuries are much, much less. All right. Then gastric other injuries are also much less. Now, these are the basic views. You can advanced TE includes around 30-35 views, but the basic views which are required in emergency situations as well as critical conditions include basically these four views. Okay, and these are at basically two levels. One is at the mid-esophageal window. The other one is at the transgastric window. In the mid-esophageal window, which is around 30 to 35 centimeter from the incisors in the middle of the esophagus, you need to get three views. You can get three views. Okay. First one is the four-chamber view, which is similar to the apical four-chamber view. You can see all the four-chamber structures. All right. Then the next one is the long axis view, which is similar to our parasternal long axis view, which you can see the left ventricle and the right ventricular outflow tract along with left atrium as well as the aortic root. All right. Then the special view is something called as a bicaval view, which is something different from our usual transthoracic echo views. Okay. Here you can see the right atrium, left atrium, and both the cava there, inferior vena cava as well as the superior vena cava. So this view is very much suitable for calculating or measurement of the SVC collapsibility or distensibility index. All right. Now SVC index is said to be much more reliable. SVC distensibility index is said to be much more reliable of hemodynamic monitoring of fluid responsiveness compared to IVC. Okay, because this is not affected by other intrathoracic pressures or abdominal pressures. One of the problems with IVC assessment is it cannot be used if there is any signs of intra-abdominal hypertension. Okay, if there is ascites, those kind of conditions, it cannot be used. Okay, it's not reliable. Then the final fourth view is something called as a transgastric view, which is almost same as our parasternal short axis view. So with that, we will conclude the part one of point of care ultrasonography. I know it has been a very long session. It's been almost 2 hours, but this topic is extremely important. And for a novice person who is not used to point of care ultrasonography, it can be a difficult topic. That's why I had to take in detail this session. And next one, we are going to have a much shorter session, and we'll be having a within this week itself. All right. So happy learning and very good night to all of you. All right. Thank you so much.